Good morning, everyone. I think we'll get started. The group is still a bit small, but I'll let people enter as they join. I've had a few people get in touch with me who've registered but aren't able to attend in person because of the school holidays, but they've asked me to share the recording, so please be aware we are recording this presentation. And a few others have also submitted some questions in advance, which I'm going to share at the end of the presentation too. But I think we'll get going now to avoid us taking too long on this. But really excited to have you all together to join us for today's webinar. You may know that the webinars are taking place within the PLA Community of Practice, which is a community of practice that's being hosted by Women and Children First, but is really run by all of the partners who work on PLA globally. This is the fifth in the webinar series. In 2020, we started with a general sort of introduction to PLA and the role of PLA in engaging communities in global health. And then in 2021, we had three webinars, one looking at how to scale PLA, particularly looking at the example from in India, where the PLA has been taken to quite large scale across the state of Jharkhand. We then also had one looking at how to adapt PLA beyond maternal and newborn health into new issues. And we also then had one about engaging communities in gender-based violence, work around gender-based violence. And then this is the fifth one, which is looking at PLA to improve child vaccination in humanitarian contexts. We're expecting to have at least one more this year and going to a schedule of about 2 webinars a year. So please keep checking your emails as they come through. We've got an exciting number coming up in the next 6 months and then in the next year. A little bit today about the presenters. We're very happy to have Dr. Andy Seal and Mr. Mohammed Jeleh joining us. Both are from UCL. A little bit of background on them is Dr. Andy Seal is an associate professor in international nutrition at UCL and works on nutrition and public health in populations affected by humanitarian emergencies caused by conflict and disasters. He co-leads the Center for Climate Change, Migration, Conflict and Health at UCL. And his research interests include the epidemiology of malnutrition, the optimization of food assistance and health interventions, and health and mortality surveillance systems. His recent research projects have been funded by the FCDO, USAID, and Bill and Melinda Gates Foundation. And he's worked in Bangladesh, Eastern Europe, and across a number of countries in sub-Saharan Africa. Jeleh is also joining us from UCL, where he's a research associate at the Institute for Global Health. He has many years of programming and research work experience in humanitarian settings, and his main research area is at the intersection between nutrition, cash transfers, migration, and the use of verbal autopsies, often within the context of population affected by humanitarian emergencies. Prior to joining UCL, Jeleh worked with local and international NGOs and the UN, and is currently a PhD candidate in nutritional epidemiology at UCL. So thank you to both of them for taking the time to present today on what we think is a really fascinating research study that was conducted recently. It's really 2 firsts, this piece of research. It's the first time that PLA has been rigorously evaluated in a humanitarian context, the adaptation of PLA into that context. As many of you may already know, PLA is predominantly has seen effectiveness in rural settings previously, and so this is the first time it's being rigorously evaluated in this particular setting. And the second piece, it's also the first time where vaccination is the primary outcome of the research study. So although the PLA approach has shown impacts on improvements in home care behaviours and some care-seeking behaviours in other settings, we've never really evaluated it at the impact on vaccination uptake. And that's particularly pertinent in all settings, but also predominantly in humanitarian settings where it's a key intervention that can reduce excess mortality. And vaccine hesitancy is high in that setting as it is in other settings, but particularly high and difficult in the setting that's a humanitarian setting. And really the question that the team was trying to answer was, can PLA be effective at reducing perinatal mortality in low-income settings? Given that PLA is effective at reducing perinatal mortality in low-income settings, can it be adapted to IDPs in Somalia? And that's really the research hypothesis they were testing, and we'll hear more about today. Just a couple of housekeeping things. As I mentioned already, the webinar is being recorded, but if you'd like to interact with us, please do. You all have access to the chat function. Any questions you have, please put them forward, because at the end of the presentation, we'll have time for questions and some answers from the panelists. We also want to learn from your experiences. Your ideas and comments are very welcome, so please feel free to use the chat for those and also to interact with each other. If you have any technical issues, I'll keep an eye on the chat, and so will some members of the team at WCF. So please feel free to use that also if you have any issues hearing or following the presentations. And finally, as I mentioned, this webinar series is taking place within a community of practice, which has more resources available to you. You can access these for free and once you join. There's a regular news articles coming out around PLA and the cutting edge issues around PLA, as well as a webinar series that you're engaged with today. We're also still working on building a forum to try to encourage the sharing of learning and practice between partners. There's also a comprehensive library of articles, published articles, peer-reviewed articles, reports, and films about PLA, which everyone's very welcome to have access to and to use. So please feel free to engage in that community of practice and also share it within your networks. The more you can build that community, the more effective the webinars and news and the forums will be. So please could do that if you can. But with that in mind, I'm going to pass on now to Andy and Jelle, who will be able to share their screens and present on this really fascinating study. And as I mentioned afterwards, please keep in mind any questions and put them in the chat. I'll follow those through and I'll make them. I'll put them to the two presenters at the end of the presentation. So thanks, Andy, and thanks, Jelle. Over to you.
Thanks very much, Mike.
Mikey, Andy and Mikey, just a minute. Mikey, our attendees, are they able to hear us? Those who
question
everyone, because one of the attendees right now texted me that I should unmute her, otherwise you couldn't hear.
Okay, so can I just check if everyone can hear us? If people could give thumbs up. Yep, I've got thumbs up coming in. Yeah, okay. In the chat. Thanks all. It looks like we can. Again, if anyone has any issues, the chat function is available to everyone, so please feel free to use the chat function. We've got some other people joining as well now. So I might just reiterate that to the new people who've joined. We're about to start the presentation. Thank you for joining. The presentation is being recorded, so please be aware of that. If you have any questions or issues, please feel free to use the chat function to raise those. I'll keep an eye on those, and I'll try to respond to them either in the chat or then as we come back from the presentation. So thanks for that, Jelle, and I'll hand back over to Andy.
Okay, thanks, Mikey. Hope everyone is able to hear. And it's a great pleasure to have the chance to present some of our results from this trial, which is referred to as the IVAX trial, Improving Vaccination Awareness and Coverage in Somalia. So as Mikey mentioned, in my research group, we normally work on humanitarian emergencies. And so for quite some time, I viewed PLA exclusively as a sort of social development type intervention, which would be quite tricky and problematic to implement in a humanitarian context. But after some time, we did decide to give it a go. My colleague Jelle, who's going to be co-presenting with me this morning, was instrumental in pushing the idea forward. And as you will see, we did manage to implement it without any undue adverse consequences and with some good solid results as well. So just going to share the full-size presentation now. And I'm just going to kick off and then I'll hand over to Jelle to continue. Okay, so in our presentation today, we're going to be talking about the main findings from the IVAX trial. And we'll also talk a little bit about some additional qualitative work we did to explore the barriers to vaccination. Because as you'll see, the PLA intervention was effective at improving quite a few important indicators, but not all of them. And the qualitative work helped to explore the reasons why it wasn't effective at improving all of the indicators that we looked at. So where did the study take place? So it's in camps for internally displaced people near to Mogadishu in Somalia. So just on the outskirts of Mogadishu, there's an area known as the Afgoy Corridor, which is here outlined in the blue rectangle. So this is an area on both sides of the road between Afgoy up in the top left of the image down to Mogadishu. And in this Afgoy area corridor, you'll get a large number of IDP camps forming during periods of stress. And this is the area in which the study was conducted. So I'm now going to hand over to my colleague, Jelle, who's going to take us through the next section on context and the design of the intervention.
Hi, Jelly, you're on mute. You're on mute. The most used phrase in the last 24 months.
Sorry. Thanks, Monkey. And thanks, Andy. Just wanted to mention that our colleague who was on the ground coordinating this study is with us, Hodan Mohammed, and she will join us during the question and answers session. So, Andy, will you try to move? Yes. Somalia is in the midst of an ongoing long-term conflict between Western-backed federal government on one side, and then on the other side, we have non-state actors such as Al-Shabaab. This is also compounded by recurrent drought. For example, at the moment in 2022, we have got a very bad drought that just happened after the 2017 similar drought. There is also, until recently, there was also the locust invasion, and then the effect of the COVID crisis. This is all happening while the health and other public services are quite poorly developed and many livelihoods lack resilience. In addition, there are many populations that are marginalized due to their clan membership. In, for example, some of the areas that are worstly affected by Ambakol and Shabelle regions, both Lower Shabelle and Middle Shabelle, we have clans that are either marginalized or minority groups. And then we have also some certain clans that speak some unique language, which may play an important role in determining their vulnerability. So we have camps for internal displaced peoples that are forming in urban areas. For example, in the outskirts of Mogadishu, a place we call Afgoye Corridor. And in this study, we conducted on one of the sides of the main road, a place called Kahda. And these are all camps that are located in private areas, which are manned by a camp leader or a gatekeeper. Health and nutrition statistics indicate that IDPs are most of the time most vulnerable to malnutrition and excess mortality. So these are examples of some examples of IDPs. The first one on the right corner, you can see the way they look. The second one with the red, you can see they got some troponin, a little bit better than the first one. And then on the right side, on the bottom, you can see these ones are new ones. And you can see the size of their houses. And where we have the circle, the red circle, that is the kind of latrine that they use. And here on the left corner at the bottom, we have some sort of a kitchen where they used to cook. And you can see the first one, that is where they cook the 3-stone fire. And then, and if you move, you'll see, yeah, that is, for example, where a woman would sit when she's cooking. Yeah, just to give you an image of what a life in these IDP camps that we are talking about would look like. So what we wanted to do was to set this IVOX trial, and the reason is because vaccination is a key public health intervention that can reduce excess mortality in humanitarian context. As you know, during emergencies or humanitarian crises, measles, for example, and diarrheal diseases are some of the leading causes of death. Vaccine hesitancy is thought to be a significant problem requiring demand-side intervention, and PLA approaches have been effective in reducing prenatal mortality in low-income settings, and we aim to apply an adapted approach in Somalia. So what we wanted to do was to use an already existing women's group called the Baya groups. Abai groups are also called sometimes Abai City, and they are all female organizations headed by a woman called Khalifada. Khalifada is a woman who must have knowledge about local history and Islam. She also must have some good leadership and childcare qualities. The majority of members are normally from the same clan or village or district, and normally would live within the same IDP camp or an umbrella. An umbrella is a group of camps manned by the same camp leader or gatekeeper. Group membership creates a safe space for women to discuss some family issues, but also provides a safe space for new mothers to gain useful childcare lessons from old and experienced women. So, for instance, a young woman who is having her first child would come to the group, would bring, for example, popcorns, and would ask all the questions that she might have, and then she would ask the groups to pray for her safe delivery. So some of the activities that happen include, for example, eating popcorns together, roasted coffee, baked beans, drinking tea, discussing local issues, and sometimes they sing traditional religious songs that we call dikri. And then there is also something called madashuk, which is led by the Khalifadda, which is pouring 3 to 4 spoonful of sesame oil on the heads of every woman that attends the session. So this is just one of the photos that we took when our facilitator was facilitating one of the sessions. As you can see, they sit in a group, and then the discussion goes on. And as you can see, there are some drinks that are ready, popcorn is ready, and then the coffee beans also ready in that traditional container. This is also a second one. As you can see, that is also another facilitator that is facilitating. And normally this is this would go on until she's done, and then that's when they start the decree. And then afterwards is when they start the eating, and then the madahshub, which is pouring the sesame oil on the heads, is the last activity that would happen. So the theory of change that we thought would be working here was our theory of change about how the PLA intervention would work was based on existing literature and reports in the area. This showed, number one, a lack of knowledge about vaccination types, schedules, and benefits. For instance, many women didn't know the different types of vaccines that existed, how many times, for example, they would take their child to the health center during the first year of their life to get vaccinations, and the different, for example, diseases that vaccination prevents, they didn't know. This also showed the existence of some healthcare and policy level barriers. So our hypothesis was that the PLA intervention would, number one, increase knowledge of group members about immunization types, schedules, and benefits. Number two, it would also encourage interaction in the community about the immunization and its benefits. And then this would enable information to reach the wider community, from the group members to the wider community. And number three, we also thought that it would facilitate meetings between IDBs and immunization providers. And here there were quite a number of NGOs that were that were working in the area providing immunization services. So the community would face them, would explain the challenges that they are facing during their health seeking, and then the service providers will try to provide solutions if they can. And as you will see later on, this is one of the things that we weren't thinking would happen, but happened and helped quite a lot our trial. Next. So the study hypothesis was that community women's abaya simply means sister-to-sister groups can successfully adopt an adapted participatory approach, PLA approach, especially distanced if necessary, to improve maternal knowledge and increase vaccination coverage in humanitarian context, and in this case, in IDP camps. The design of our study, the intervention was an adapted participatory learning and action circle or PLA approach, and we aim to assess whether PLA intervention run in partnership with abaya groups could improve the uptake of vaccination services in for IDP children. And we designed a cluster randomized control trial, which was implemented in 10 camps. The original design had 12 IDP camps, as Andy will explain later on. During the results section, we lost 2 of them due to evictions that regularly happen in the area. And then we we recruited external facilitators that were trained using an adopted training manual. Initially, this training manual was developed by Women and Child First, and we ran 8 meetings in one circle to address topics of child health, vaccination, analyze challenges that exist in the area, and then plan and implement potential solutions, local solutions. What were our outcome measures? We had about 5 primary outcomes and 1 secondary outcome. The primary outcomes were measles vaccination coverage. We also wanted to increase completion of pentavalent vaccination series. And this was mainly because measles vaccination or measles vaccinations play quite important role in reducing the risk of death during measles outbreaks in humanitarian crisis. And the pentavalent is used as a proxy indicator of completion of the primary series by WHO and the Ministry of Health in Somalia. So we wanted also to test that one. And then thirdly, we also wanted to see if we could increase timely EPI vaccination coverage in Somalia, or in this case, in the IDP context. And then we also wanted to see if we can improve maternal knowledge and then maternal attitudes towards vaccination. And then we had 1 secondary outcome, which is possession of health record card. This is the standard PLA circle that, as you can see, that has 4 phases. Roughly each phase would have about 3 meetings, and in total, this would be about would have about 12 meetings. And we adopted these. So what did we do? Next. So this is the adapted circle that we have. As you can see, we have the red triangles, which show the baseline and the end line. So we started with the baseline, we conducted the baseline. And then after that, we went into circle 2. Next. Phase 2. And in phase 2, because these were already existing women's groups, we didn't spend time in bringing them together, introducing them each other. So the introduction that happened was our facilitators and research officers going to their meetings and introducing themselves, and then also introducing the topics of discussions, and then asking them to allocate some of their time during their discussions. So that was meeting number 1. And then meeting number 2, we focused on identifying child health problems, all the child health problems, and then prioritizing 3 of them. For instance, in many of the camps that we worked, in 5 of the intervention camps, they identified about 16 to 20 health problems, and then they prioritized 3 of them. Luckily, in all camps, those prioritized were number 1, measles and pneumonia. And then others that the third one could be, for example, malnutrition, or it could be respiratory tract infections, it could be diarrheal diseases, and so on and so forth. But the first two that all 5 intervention camps identified were measles and pneumonia, sorry. And then we went to phase 2, Andy. Good. And in phase 2, we had 3 meetings. By the way, these meetings happened weekly. So every week there was one meeting that was happening. So for instance, in phase 1, these 2 meetings happened week 1 and week 2. So in 2 weeks, we finished phase 1. And then phase 2, we had third meeting where we identified prevention and management practices. And then in meeting 4, we identified local solutions. And then in the triangle there, we prepared for a stakeholders meeting. And here, stakeholders, what we mean is where the service providers and the IDB members came together to present whatever they were talking about. The IDBs present whatever they were doing, and then talk the challenges that they face during their health seeking with the service providers. And here, some of the service providers agreed, for instance, to come up with solutions. So some of the challenges that IDBs were reporting were that, for instance, many of the people in the area do face covered long distance when seeking during their health seeking, or when looking for places to vaccinate their children. And what the service provider tried to do was provide, for instance, mobile teams or mobile clinics who would provide vaccinations within the camps on certain days. So rather than the IDBs going all the way to the health facilities, the mobile clinics would come, they would be mobilized, and they would be vaccinated within their camps. And then the surrounding camps also can come during that day and make use of that opportunity. And then we went into phase 3 next. Phase 3, we first planned for solutions. That was the week where we planned how the solutions will be implemented. And then we took about 2 to 3 weeks to implement the solutions that were locally appropriate solutions that could be done. So some of the solutions, for instance, that was suggested that we were applying here included, for instance, many of the mothers said that they would go and they would do some cleaning, for example, clothes for wealthier families, and that is some sort of labor or manual jobs that they do, and that's how on the top of humanitarian assistance, the way they meet their daily bread. And they were not able to go and take the children for vaccination. So one of the things that we were doing was for example, the health service providers, to help them bring to their doors the vaccination, which is the mobile clinics. Number 2, try to mobilize them and inform them about the benefits of dedicating some of their time and taking their children to the vaccination centers or to the mobile clinics. And then number 3, those who were not available, then there were volunteers who said we would help them, for example, their neighbors or their relatives who said we would help them take their children to the health facility if they would want us. And then some of the women, for instance, also said that they have younger children at home, and even if they wanted to take their children to the health facilities, then they said they can't leave the other younger children at home alone. And in that, there were also some volunteers who said, we can come and help you babysit. So those are some of the solutions that were done. and the biggest one being the biggest one being the mobilization and then creation of awareness about the benefits of the vaccinations, the schedules of the vaccination, and where to get, which were led by the Abaya group members. And then after that was done, we ran the online survey. Next, Andy. We did the end-line survey, that is phase 4. And then once the end-line survey was finished, what we did was we had another session where we feedback the community about the result of the end-line survey. And we also asked about what they felt about the process, and if they would want to repeat and use it, for instance, for other challenges that they might have, other areas. We also try to evaluate some of the solutions that they selected, that they felt were quite successfully implemented, and those that were not successfully implemented, and the reasons why they were not successful. And then the last meeting was an observation meeting. It was not facilitated. So our research officer and facilitator would just attend one of their meetings to see if the topics that we discussed continued after the facilitated meetings. So in general, those are some of the adaptations that we did. And mainly, as you can see, the last 2 happened after the online survey. So if you look, we had about 6 sessions that happened before the online survey. And in general, this whole process took us about 3 months. This also includes about 10 days that we didn't do any work because one of the facilitators got COVID. So we had to pause the process. So that is what we did in the adaptation, and the main reason why we had to shorten everything in 3 months was because in humanitarian crisis, funding is normally for life-saving, and it continues about a year. So if you want to plan a study and conduct it and then complete within a year, then the data collection or the actual phase of the intervention has to be quite short. And what we wanted to see was something that's quite short and that is applicable in humanitarian contexts and is scalable, and it seemed to have worked. Over to you, Andy.
Thanks, Jelly. So now I'm going to take you through the results from the trial. And this trial and the whole process was funded by the Bill and Melinda Gates Foundation. And the work we did was very much in close partnership with Action Against Hunger. And as Jelly mentioned, Hodan should be joining us for the Q&A from Action Against Hunger. So the data from on this figure 1 shows how we selected the households. Initially, we did camp mapping and household counting to identify that. I'll show you a couple of images from Google Earth to illustrate that process. We identified 12 camps, which we were going to use in the trial, but immediately before we were about to start, we lost 2 of those camps because they were subject to forced eviction, which is something which occurs quite commonly in these IDP camps in the Afghan corridor. So that left us with only 5 clusters per arm, and those were randomized to control and intervention. So this goes back to the map of the Afghan corridor, and the first stage, which Hodan and others were involved in, was mapping the actual location of the camps and then finding out which camps actually had abaya groups. And as we found out, there were groups of camps, or camp umbrellas, as they were called, with an abaya group. So an abaya group perhaps would cover 5 camps or so. And after we'd mapped all of these, and this is just looking at a bit more detail of what that mapping looked like, we were then able to select the 10 camps with abaya groups, which were reasonably spatially separated. So the outcome measures we've already been through, so I won't mention those again. This moving on now to shows the flow chart for the participants, the individual participants, children and mothers. We were very pleased with the follow-up. For example, with children, we only had about 10% loss to follow-up in the intervention arm. So we were quite pleased that we had a good level of follow-up. The baseline characteristics of the camps are presented here. So generally, they were fairly well balanced with no striking differences. There were a few two significant differences in the HPLA intervention camps. The age of the mother was slightly younger, and the education level was slightly different. Also, in the intervention camps, more mothers had received a vaccination during their last pregnancy. So there were one or two differences, but nothing that we felt deserved adjustment for. The characteristics of the children, aged 0 to 59 months, are presented here. And again, generally fairly well balanced, although the use of mosquito nets was again higher in the intervention camp, but not significantly higher. So here are the main trial outcomes. So as we mentioned, we did the baseline study. We had about 3 months of intervention, and then we conducted the end-line study, and we're comparing the difference in the control in the intervention camps between baseline and end-line, and looking at the odds ratio of that difference. So these are the 3 primary outcomes which gave a significant result. So the caregiver knowledge score in the control group increased from 7.8 to 8 in between baseline and end line, but doubled in the intervention camp from 8 to 16. So that gave adjusted odds ratio a score in this case, of course, of 7.9, highly significant increase in knowledge score in the intervention camp. Measles vaccination improved somewhat by about 3 percentage points in the control camps, but much larger increase was seen in the intervention camps with a odds ratio in this case of 2.4. Pentaseries completion showed a similar difference with some improvement in the control, but much larger improvement in the intervention. Then the other indicator which did show a positive difference was in the position of child health record cards, where we saw that going up from 18 to 35% in the intervention camps. But it's important, of course, to also look at what didn't improve, and timely vaccination didn't improve. And then we'll talk a little bit more about that in a second. The other thing that didn't really improve was preference for vaccination. But we have to bear in mind that the baseline levels were already high at about 95, 96% at baseline. So there was little room to see any significant improvement in that indicator. So we weren't surprised to see no difference between the camps. We were somewhat surprised to see such a high level of vaccination preference being expressed at the baseline. But now I want to really turn and hand back to Jelly to talk about some of the reasons why timely EPI vaccination did not improve despite the improvements in measles and penta coverage. Just before I do, this slide here just summarizes by individual antigen the improvements that we saw. So this is a difference in difference arithmetically calculated for each antigen. And we saw quite some nice large improvements in many of these antigens. But now want to focus back on the issues about why some things did not improve, and hand back to Jelly to talk about the barriers that we found that would prevent better uptake of immunization. Well, uptake, in fact, rather than upbreak. But back to you.
Thanks, Andy. To do that, what we did was we conducted some qualitative work on within the IVAX study. Here we carried out health facility assessment, and then we also did scoping review of policy documents. And here we're talking about EPI policies, guidelines, either from Minister of Health or MOH in Somalia. And we did descriptive qualitative work. And then we used a socio-ecological model for analysis. Next, Andy. So the socio-ecological model has 5 layers. We have got individual barriers, interpersonal barriers, community level barriers, organizational level barriers, and then policy level barriers. And we wanted to see all those. And at the individual level, we have seen that, for instance, as we mentioned earlier on, as was shown by our literature review when we were developing the theory of change, lack of knowledge existed. And here, when we talk about lack of knowledge, we're talking about basics, like, for instance, not knowing the different types of vaccines that exist, the schedule, the vaccination schedule, whether or not children can get multiple vaccines at the same time. And then there was mistrust when it comes to some vaccines, with some reported cases, for instance, and IDBs or parents asking if vaccines are there to make them barren or not have children. And then there were some sort of concerns about side effects. And then, as I mentioned earlier on, there was opportunity cost in that many of the people there depend on labor work, and many of them many of the households are female-headed households, and many of the mothers do go look for work during the day. And then others reported cost of transportation. At the interpersonal level, it was reported that there was influence from certain family members, such as the husband and mother-in-laws. And in this case, what was said was that even if a mother wanted to vaccinate her child and was convinced to do that, the final decision maker is the husband. And if he says no, most of the time, she won't be able to vaccinate her children. And then mother-in-laws, especially the mother of the husband, were also said to be quite powerful. And if they are anti-vaccinations, then they would not allow their grandchildren to be vaccinated. Cultural and traditional norms also play, and then gender roles and decision making was also mentioned. And then what also was mentioned quite regularly was eviction, in the sense that eviction is quite rampant in the area, and many of the IDB camps do experience evictions. And those who are evicted to further areas away from where health facilities are normally would face difficulties in coming back to the same health facilities where they were routinely vaccinating their children. Yeah, okay, thanks. And then at the organizational level, and here we're talking about the level of the health facility. There were reportedly some barriers. For instance, the IDBs reported long waiting times when they come to the health facility itself. And then they also reported vaccination stockouts, and this was also reported during our health assessments, in that in almost in all the 5 health facilities that were assessed, they mentioned that they routinely experience stockouts. And then IDBs also reported long distance traveling longer distance to reach, especially those who are evicted, as we said earlier on. And then some, both IDBs and health providers also reported language barriers. And here there are unique language dialects such as the Jido, and those who speak normally face difficulties in getting people who understand them. And another one that was quite prevalent in the area was hesitance to open multi-dose vials, in the sense that in all the health facilities we assessed, they mentioned that they open measles and BCG vaccines twice a week, and those who come other days will not be able to vaccinate their children. So what they would normally do is they would record the name and the telephone number of the mother, and would call them when the day for opening the vials of measles and BCG comes. So that was those were some of the issues that were reported at the health facility level. At the policy level, what we found out was a bit of lack of clarity, for instance, when it comes to eligible age of routine vaccinations. For instance, in the current EPI 2020 policy, it mentions that all children below 24 months are eligible to get the routine vaccines. However, in practice, on the ground, only children up to the age of 12 months are eligible to get routine vaccines, and any child who is older than that would get only measles and polio vaccines. So that is, for instance, one of the things that exists. And then when it comes to catch-up vaccines, that also exists in the sense that catch-up vaccines for children above 12 months do not necessarily happen. What happens is every child who is older than 12 months would only get measles and polio vaccines, including even those who started the series when they were younger than 12 months. There was a bit of confusion. While some people said if they started the series when they were younger than 12 months, then if they come after they turn 12 months, older than 12 months, we would complete the series for them. Most of them said that's not the case. They wouldn't continue the series. They would only give polio and measles vaccines. And then for certain antigens, there was, for instance, age restrictions. For instance, BCG, they would only give children up to 1 year. So above 1 year, they wouldn't be able to get. And then for example, OBV0, they would only give children at birth, and if that doesn't happen, then they wouldn't get it. And then another thing that we found out was that for most of the time there is a process called OMUL, and OMUL is the seclusion time, when the period when a woman who just delivered would stay at home and would not take that child out of the house. And within the context of Somalia, that is about 40 or 45 days? Hodan will correct me later on. And during that time, then and remember, in this context, it's quite common for mothers to deliver at home. So and they would miss all vaccines that they would have got, the child would have gotten at birth. However, some of the vaccines, if they decide to go after the OMUL period, then they might get like BCG, but not OPV. So those were some of the barriers that existed in the area that we thought probably could have led to some of our outcomes not improving. And now I will hand over to Andy to continue with the conclusion and the recommendations. Over to you, Andy.
Thanks very much. So to summarize our findings, in this context, the PLA intervention resulted in a doubling of the maternal knowledge score. Coverage of both measles and pentavalent vaccination improved markedly. However, adherence to timely vaccination did not, and as Jelly's just been explaining, some of the barriers that exist to achieving that were not really amenable to intervention using a PLA approach, but would require other supply side or policy level interventions. Possession of a home-based child health record card also increased, which was very welcome, especially given the very low level of child health record cards in this population and the problems of recording accurate vaccination records. We should also mention that during the study, a total of 16 children died, 10 boys and 6 girls, but there were a comparable number of deaths in each camp arm, or rather each trial arm. There was no reason to believe the deaths were associated with the intervention or prevented by the intervention. So conclusions and recommendations. One, we would like to propose that an adapted or humanitarian PLA approach can run in partnership with Indigenous social groups and achieve important changes in health knowledge and practice in this type of humanitarian context. We feel that further work to scale up the approach in IDP and other population groups within Somalia is warranted, given the results that we found with this trial. And the evidence that it can work to improve vaccination suggests that it might also be a useful intervention to try and address other targets, such as improving child diet diversity, detection of malnutrition, IYCF type interventions, and could therefore potentially be an alternative type of intervention to NGO created mother support units or IYCF focus groups. So we would like to suggest that using the Abide-by PLA approach, we might be able to use that as a platform to address a range of challenges which are normally addressed through other NGO created types of groups. We found in this study that it was really important to have that interaction between the beneficiary or the service users and the service providers. And this PLA approach can improve demand for health services and help them to enhance the reach that the services achieve. And so this engagement was really critical. And it, as well as helping to improve coverage, this has also, of course, helped humanitarian service providers to meet their obligations under accountability to affected populations. Under that agenda, the AAP agenda, it's important that humanitarian providers are accountable to their populations, and there are mechanisms in place to ensure that they're delivering services which meet the needs of the population and are also delivered in a way that is appropriate, and that the use of this PLA method can help the humanitarian agencies achieve those affected accountability to affected population objectives. So there's a potential to integrate the PLA approach into cash distribution programs to try and provide a cash plus integrated approach, which is more likely to achieve humanitarian objectives rather than a cash transfer on its own. So that's really what we wanted to share with you this morning. Mikey, back to you.
Thanks, Andy. Thanks, Jelly. That was fascinating, really fascinating and exciting. I think fascinating because we've learned about a context in which PLA has not been implemented before, but also exciting to see the potential for this. As many of the people on the call on the webinar today know, we're as a network exploring the boundaries that PLA can expand into, and we recognise there are clearly limits where it can't have an impact. Previously, we had assumed that this sort of context, which is highly complex, not only complex just because it's an IDP, but also complex with the time available you had to do the study to run the groups. Also because of COVID-19 and the other kind of pressures on the population there. So we always thought that this was one of those boundaries. So it's exciting to see that potentially there is opportunity in this area to bring PLA, to bring benefit to the communities there. So I'm going to open up the floor to questions. I have a few that have been sent in by email, which I will get to. I'm hoping that people will use the chat. I've already seen that one question is on the chat. If other people would like to ask that questions directly to Jelly and Andy, then please do use the chat function to do so. But I thought I might get the ball rolling with a couple of questions that I had. And the first was speaking to that issue that I just raised, that we assumed that IDP settings would be highly complex for PLA. PLA is generally something that you have to have running for a relatively long time with a static population where people have some sort of pre-existing social capital where they, they often they share an ethnicity and language. They share some sort of reciprocity between members. We'd assume that IDPs in many cases wouldn't have those basic criteria in place. So I'm wondering about the transferability to other IDP settings. Do you see that this is an approach that is amenable to certain IDPs, and maybe more static IDP settings or kind of more continuous displacements, or do you think it can also be amenable to other settings? So really thinking about the transferability of PLA to other IDP settings and your thoughts on that.
Maybe I could kick off on that one. The IDPs in this context weren't totally new. They'd been in this in the camps. They'd been living there for a number of months. So that's one thing to bear in mind. But I suppose we were surprised to find that these abide-by groups exist in this context and are sort of integrated within the IDP camp structure. It was there. That's really what inspired us, I think, to give this a go, was when we started to learn about the abide-by groups and the fact that they actually hadn't been up to that date included in any of the sort of the SBBCC activities of NGOs. So it seemed to be an opportunity. So they're there in this context. And of course, it raises the question about what other groups could be used in other types of contexts. So yeah, I think it's obviously it should be a case-by-case analysis on what can work, but I think there is definitely potential. Another factor you mentioned about sort of social capital in these situations where people from the same clan, same district would be living in the same camps. Often the camps are given a name of the district or the village from which people have come. So they do have that sort of social identity with their fellow camp members often. I don't know if Jelly wanted to add anything on that.
Not really, no, Andy. But Hodan, who is from Mogadishu and has done this work on the ground, is with us. Hodan, do you want to add something?
I'm just checking. Hodan, I think I've unmuted you, so you should be able to speak if you want to, or use a chat if you want to mention anything by chat.
Okay. You can go on with the other questions, Mikey. No problem.
Okay. No, that was again fascinating and really resonates with what we found. As you know, PLA is recommended in rural settings. That's where we feel that it has most likely effect. Where we've seen it's worked in sort of peri-urban settings has been again in exactly the same criteria you mentioned. It's where people have migrated together to an area, peri-urban area around a kind of a town or a city centre, and are still living together, therefore still share those relationships they've brought with them from the rural areas they've migrated from. And we've had an experience of using PLA in Myanmar in an IDP setting, but again, quite long-term established IDP settings where people have rebuilt those social networks and that social capital. So it feels like that remains a key criteria for thinking about transferability of PLAs, that's some pre-existing social capital needs to exist to maintain and support the group to take social action. A couple more questions have come in, but I've got one last one from me before I go to the ones that have been coming on email as well. And that's around working with abide-by groups. Again, fascinating this social grouping exists and that it's amenable to layering PLA on top of it. What I'm interested in is where we've worked with existing groupings before, there's sometimes been some constraints in doing so, in that those groups often maybe have a closed membership, or maybe they've been established with maybe a financial remit where they've been money sharing or group funding within the group, and therefore they're less amenable to new members joining and accessing the benefits of the group. And I was wondering about the abide-by groups themselves about how exclusive they are or how inclusive they are, and again whether that's another thing to keep in mind with working with other groups in other settings.
Again, I think that the best person would be Hodan. Hodan, can you hear us? Okay, then if you can't hear us, I will give it a go. In this case, what we found out was that bio groups are exclusively only women kind of platform, and but what existed was that women would contribute either in kind or in monetary form to the meetings, but they were not closed. So whether you paid or not, as long as you were willing to come and join, then they would allow you to join. And for women, for instance, who are young mothers or who are pregnant, they were even encouraging to join, because many of the attendees of their bye-bye groups are older women who had very good experience in having their own children and child caring. So it is an informal kind of knowledge sharing session for them, even before we ran our PLA circles there. So in a nutshell, they were exclusive in the sense that it was only for women, but within the women it was open and everybody could come. So it was not only few members who were able to attend.
Fascinating, thank you. And just checking again, Hodan is registered, and I've unmuted, so I'm just checking. Oh, she's got a connection problem. So hopefully Hodan will be able to join if she can keep trying. Hopefully she'll be able to get some access. Thank you, that's really interesting. I think turning to some of the questions in the chat, we had one about vaccination hesitancy. Did you find the reason people didn't get vaccinations were because of practical barriers, such as childcare requirements, versus misinformation? I think you've answered that to some extent, but it'd be interesting to hear a bit more on that and where you think the balance was in the end around kind of those key barriers to access vaccinations.
Yeah, we did find some key barriers, practical barriers. As I mentioned, many of the mothers there that get humanitarian support, but also depend on casual labor. So many of them would go out to look for some of that casual labor during the day. And there existed quite a big opportunity cost in whether to take children for vaccination or whether to go and look for the daily bread. So that existed. But also there existed misinformation in terms of the role of vaccines. And that helped the fact that we had community mobilization led by members of the community going around talking about the benefits of vaccines, the schedule, where to get it, when to get it, and the different types of vaccines that exist, did help, because it makes a lot of difference when one of your neighbors is telling you, this is something I had the same mentality that you had, but now I think this is what is happening, than when a health worker is coming and talking to you about their profession and what you should be doing. So I think both of the barriers that was asked exist, and I think in general what we felt was, although the individual level barriers existed, we were quite surprised that the policy level barriers that restricted children above 12 months getting routine vaccinations was quite shocking for us, and I think needs immediate remedy.
Interesting, thank you, that's really clear. And I've seen there's some questions come in, but that links to a question that someone else has asked by email, which is around the barriers. And I know you made it clear from the diagram you showed that there were multi-level barriers influencing people's ability to make choices about vaccination uptake. And clearly there are some, as Andy, you mentioned, which are out of the control to some extent of the ABI groups or the PLA groups, which are the policy or the supply side barriers. But there are others in there that seem to be amenable to PLA. So, for example, the misinformation pieces, the misconceptions are things that PLA in other settings has really had an impact on. Do you think that running the PLA process for longer would help to address some of those other barriers, or do you think that they are beyond the scope of PLA and would require a separate intervention?
I think we don't know for sure what would happen if it was run for longer, but I suspect some of the policy level barriers, would need other types of interventions to make them move. Possibly publication of academic papers might contribute to part of that, but I think that would only be a part of the process, or could contribute only in a small way to making things move at that level.
Interesting. I see there are two questions in from Janet Micheni, so I'm going to go to both of those, and maybe we can answer them together. The first one was that she's interested to understand if these groups were present in new arrivals. I'm assuming there you mean were new arrivals present in the groups. And the second question is there a plan to assess the continued benefits of the approach after maybe 6 months or a year, so the long-term benefits of the approach beyond the kind of headline survey you conducted? So if you're able to cover those two questions, that'd be great.
Yeah, and the camps weren't specifically for new arrivals, so they've been established for some time. And it's a really good question, how quickly ABI groups become established in the sort of the context we're seeing at the moment. We've got large numbers of people migrating due to the drought emergency. So that's a really interesting question. But I think, again, if Hodan has a connection, she could comment as well, because I think Action Against Hunger have done some follow-up work to look at where groups are found in other areas that they're working, and they seem to find them pretty much everywhere, actually. So, but that still leaves open the question, how quickly would they become established in a new influx camp? The second one, sorry, that Janet had was
around your plans to assess the continued benefits longer term.
We would love to, but I don't think we ran out of money. So we would like in the future trial to look at a longer term benefits. Yeah, there was no funding available to us to do it this time.
That's interesting. Yeah, and we have, again, from rural development settings, we have evidence of long-term sustainability, but clearly in this setting would require further evaluation to see whether it can sustain in what is a much more complex and mobile situation than we have in a rural setting. Thanks for those questions, Janet. There's another one from Dereje from Ethiopia asking, in addition to improving the demand side, PLA is supposed to challenge the supply side barriers. Is this the case, and how effective was it? I know you mentioned some work around mobile clinics and maybe improving the accessibility of services, encouraging health providers to provide services. Is there anything else they engaged with, and anything else you can talk on that issue?
Yeah, that was really important particularly through the stakeholder meeting, to bring together the service users and the service providers and get them to talk to each other about the challenges that both were experiencing and how they could optimize the services. Jelly, anything you'd like to add on that one?
Yeah, in addition to that, also, when we were implementing our local solutions, the ABI group members were mobilizing communities, and they would normally go, those who are mobilized and who accept to vaccinate their children would go in large numbers. So that also challenged the health facility or the health providers to be ready with supplies and to be a bit open-minded when it comes to the days to give certain types of vaccines.
That's interesting, and again resonates with what we found in other settings. The groups are able to affect those sort of social accountability change around accessibility quite effectively. What's harder is maybe the quality of services and the availability of stocks of drugs and things, which are much harder for them and much more distant from the groups, and that normally takes a much longer period of time, and a more networking of the groups working collectively, not just one group working directly with the health facility, but collectively many groups working to advocate for better quality of services. So again, interesting to see that in a large-scale trial, maybe with more groups involved, whether that could be something over a long period of time, you'd start seeing some changes there as well. One question that's come in from email is around male involvement, and clearly you've already mentioned that Abe groups, although open to women to join, were closed to women-only membership. And I suppose how they interacted, interfaced with men to make sure that the men in the community were supportive of the actions we're taking, or weren't obstructive in any way. So I was wondering a bit more about someone was wondering more about the male involvement in the process.
I think Holland would be the right person again for this one. Holland, are you able to talk this time round?
Hello, Jelly. Can you hear me right now?
Yes, we can hear you finally. Yes. Did you hear the question?
I think I heard it was talking about males inclusivity in the process. Actually, as Jelly has mentioned earlier, Abai is a female inclusive only group, which mainly women come together as a safe space and they perform prayers. But throughout the process, males were involved during the community meeting or stakeholder meeting, where we invited community leaders, local leaders, other male partners, and as well as the health service providers. That's where they engaged, and actually they have shared their input, how the mothers have conducted so far, how they identified the problems they were facing, and how did they come up with the solutions. And actually it was something that resonated with them, and they give their speech and support to the groups as well. So targeting was only based on the women groups, but inclusivity was done at the stakeholder meetings. Thank you.
That's fascinating. Thanks, Hodan. I'm glad you can join us and speak. Another question that's come in is around the potential route to scale. So clearly you've done the smaller scale trial, you're looking maybe to do a large scale trial to prove the effectiveness on a larger scale. And whether there are structures or processes in place through which you can scale this approach in IDPs, not just in Somalia, but elsewhere. It'd be good to hear your thoughts on that.
I think one opportunity provided in this type of context is that NGOs tend to be running some sort of behavior change communication work already. Some sort of campaign is ongoing. So we're suggesting that this could be an alternative route to do that type of work. So if they're spending money, for example, on running IYCF groups at the moment, then it would be worth, we think, exploring doing that same thing, but through the Abai group. The advantage, potentially the cost effectiveness of that could be that the group is likely to sustain. It's already there. Generally, when you start, it's likely to sustain itself after your project funding finishes, and therefore would be next funding cycle, you're likely to then have a platform there which you can then re-engage with as funding becomes available. So I think it has quite a lot of cost efficiency advantages potentially in terms of scalability. What we're hoping to do next in the next study is to look at how we can best scale it. Do facilitators have to be specially trained individuals selected for their particular attributes to do that, or can we use community health workers to interact with the Kalafaida? One of the ideas in the original trial that we just described was to work directly with the Kalafaida and get them to facilitate the meetings, but that didn't really turn out to be practical due to the low literacy rates of a Kalafaida. So we really needed people who are literate, because so they can work with the material in the manual. So there's some really important questions still to answer, I think, about the best way that this could be scaled up.
That's very interesting, Andy. Yeah, and I know we've spoken about this before in terms of using the community health workers or Kalafaida as facilitators. And as I've talked about previously, and many other people on this call will understand, we have been able to run PLA groups in low literacy areas by using some adaptations of the approach, and whether it's using audio manuals or whether it's using other people in the community to support the literacy aspects of the role, and leaving the Kalafaida maybe to lead the actual delivery of the intervention. So there are ways around that potentially, and it'd be great, as we talked about previously, to explore that in further studies. So thanks for that. I think that there's one more question that's coming on the chat. Oh, go on, Jelly. Yeah, go ahead, Jelly.
Yeah, in addition to what Andy said, also there appears to be a move away from the yearly humanitarian funding that donors would typically do to multi-year funding that donors these days provide, which involves, for instance, safety net, which continues a long time. And Janet, for example, who is with us, is working for a consortium that does that. So in those long-term funding in Somalia and similar contexts, there exists those kind of consortia where there is long-term funding, multi-year funding, and I think that also provides a platform for scale-up of PLA type of intervention.
Thank you. That's fascinating. I think that there's another question coming on the chat, and then I've got one more from the email. And hopefully, if there's any more questions, please feel free to put them in. We've got about 5 to 10 minutes left. Joe's asked, what do you think could be the advantage of PLA for vaccinations in humanitarian settings over other demand-side focused approaches currently used? You've already talked a little bit about IYCF groups and activities and other things, but it'd be good to get your sense of how you've come around to PLA being kind of an interesting and potentially high impact intervention when there are other interventions already ongoing, potentially health education style interventions or more traditional SBCC interventions already ongoing, where you see the benefits of this are compared to those existing interventions.
Yeah, I think for me the potential cost effectiveness of it is a big thing, and you're working with groups that are already there and are likely to be there when your project finishes. So that's one thing. The sort of the institutional sustainability of the structure is important. Also, the acceptability and the credibility of it within the organization, the social organization. So the Caliphate, for example, are selected because they have certain attributes that they are seen to have by the community, and they're elected by the group. So they already have some kudos, should we say, some credibility within the membership. Whereas if you put in a community health worker, for example, to do an activity, behavior change activity, that person may or may not have a suitable level of respect or credibility within the social context that they're working. So I think there's a number of advantages. And yes, I was very much open-minded about, I had real equipoise about whether this was a good idea or not until we actually tried it, and it seems to be.
Brilliant, thanks, Andy. I've also seen a question just come on chat from Keris asking, I'm interested to understand what integration with Cash Plus programs would look like and what impact you would expect this to have on the uptake, effectiveness, cost effectiveness and scalability of PLA in IDP contexts. So yeah, a little bit about how you see that integration happening and what impact you think that might have.
Is that for me? Yeah, okay. In previous studies, we did some work on the mHealth, and we after we have done this IVAX study, we were thinking probably this would work well with a Cash Plus. For instance, if we were providing cash for communities, one of the things that could easily be done with the PLA approach is facilitating, as we did right now, and given the cash will support with communities in the sense that they at least don't necessarily have to think about where their daily bread is coming from. I think this would help them focus on the health aspect that is quite needed. We think not only that the cash will just provide an incentive as such, but by virtue of having the cash in place, I think what the role that the PLA can play is, for instance, improve vaccination coverage. IYCF also could be another thing that could be focused, which could play quite a good role in reducing morbidity and mortality. And then we also think child diversity could also be another issue that could be looked at. Andy, probably you wanted to add something on that.
Yeah, thanks. I suppose it's a way to nudge people how to make their decisions about how to spend the money that they've received. So we're not suggesting it should be a conditionality, but rather it should be a way to nudge people. So often in people generally, I think it's a good idea to have some behavior change communication going on alongside a cash transfer. And this would be an alternative way to do that, to try and encourage people to make decisions which are beneficial for health and nutrition.
Yeah, very interesting. I think that's certainly how we see PLA working again in other contexts. Is it's an opportunity for people to support each other in their decision making, to also to pressure test their own decisions against those of others to see how acceptable, appropriate they might be, or how feasible they might be. It's also a way to break down sort of those mega messages, those messages you're receiving from all sides about how you should be spending the funds you have or the cash you have, and break that down into easily digestible actions you can actually take yourself. So it'd be fascinating to see those two things brought together and see if that could have additional benefit, additional value. I think we've got time for one more question, and there's the perennial question that comes in around COVID-19. I really feel for you and your partners and your teams. You not only had to do this in a very complex setting, but also at the time of COVID-19. And really trying to understand whether you saw any impact of this approach on maybe prevention or management of COVID-19, or whether you slightly missed that, and this happened slightly later. What we're finding in other settings is that the PLA approach seemed to have provided some resilience, again, some opportunity for people to meet and share information and share support, and a way for people to take messages that are coming down and take them out to the households in the community that maybe have less access to those messages. It'd be interesting to see whether it had any impact in your setting on COVID-19.
Yeah, we had lots of discussions, as you can imagine, about whether we should do this at all, or when and how is it possible to make by groups COVID safe. And the actual implementation was delayed and then paused again due to one of our facilitators catching COVID. Yes, I mean, it's inherently not a COVID safe thing to do, to bring lots of people together and put them together, get them to sit close together and eat and share drinks and talk to each other. Obviously, it's going to potentially enhance transmission of respiratory infections. Balanced against that, yes, all those positive things that may come from that group in terms of mutual support, coming up with ideas, spreading messages around how to deal with the ongoing crisis. So yes, I suppose the takeaway, it was difficult to do this. It added complexity. It delayed the implementation, and I don't think there's any way that we would say that it's a good thing to do per se in like a situation like COVID. To bring lots of people together and get them to sit together and talk at each other for a long time is not a good idea in terms of transmission.
And Jelly and Hodan, what about, did you see any impact though on, or once you were able to bring people together safely, whether that would have an impact on their sharing of knowledge or information or support around COVID-19? Did that happen organically, or was that something they didn't discuss? They focused just on the child health vaccination issues that were kind of a primary focus of the groups?
Then can you hear the question? Do you want to take this one? Yeah, I think she also she has again connection problem, but in general, I think she was on the ground and would have given the best answer. But as far as I know, in Somalia at the moment, COVID, when we conducted, existed, but when you talk to the community, they would tell you that they have got major challenges that they are facing. So COVID to them was not the major challenge that they were facing at the moment. They were facing, for instance, being new into a new context, not having enough money to feed their children, other diseases that were quite rampant in the area already, struggling to get clean water, not having, for instance, latrines to help themselves. So the challenges were quite many, and COVID was one of them. But luckily, we were working with Hodan, who is a medical doctor, and ACF, and they put some measures in place, for instance, trying to provide face masks, to provide hand sanitizers. So to a certain degree, they try to put some measures, preventive measures in place. Hodan, if you can hear us, do you want to come in?
Yes, thank you, Jelle. As Jelle has explained, I think that was what's on the ground. Actually, we asked before we started conducting the PLA meeting cycles, how COVID influenced the participation of the bye-bye groups. And we have noticed much of the bye-bye groups continue and they don't have an issue with COVID. Also, groups explain that they do some measures and follow the guidelines of the MOH by minimizing group participation, as well as placing hand washings and face masks. Groups somehow mentioned that everyone should take a cloth face mask from their homes to be part of the meetings. Also, we have seen some groups that have mentioned that when COVID-19 was peak, that they have stopped doing the bye-bye groups, and when they see the cases are going downwards, that's when they start doing the bye-byes. In addition to that, groups also have mentioned that they do their bye-bye groups for prayers, asking God to prevent COVID to happening to that community and praying for that community. So they feel that it's a sense of seeking help from God for their own beliefs, like assisting them in just preventing having this issue by asking God's forgiveness and protection. So it was not one of the key diseases mentioned during the identification of the problems. Yeah.
Okay, thanks, Hodan. That's really interesting. And
I think maybe just an additional thing was one of the other measures we introduced to try and reduce COVID risk was initially everyone at the meetings, the attendees, would be recorded so we could keep track of the numbers. But we suspected that some people were showing up at the meetings just to make sure they got their names on the list, because in this sort of context, people often associate that type of activity with registration for some benefit or some distribution. So after we discussed and decided not to then register everyone at the meetings in future, to try and manage the number of people who were attending and just get the people who were actually interested in being at that meeting rather than just being there to register for some potential benefit that they thought might come.
That makes sense. Thanks, Andy. And thanks, Hodan. And thanks, Jelly. Thank you all. Hodan, I'm glad you managed to join and speak just a little bit. I'm sorry we weren't able to connect you for the whole session. But thank you for joining, and thanks, Andy and Jelly, for your presentation and answering all the questions. Thanks to all the people who've joined for their pertinent questions and their engagement. I just wanted to finish by saying again, it's a really fascinating piece of work, a really exciting piece of work for so many reasons. We're very keen to continue supporting and working in collaboration to see where this goes for PLA in this context, because again, it allows us to find out where the boundaries of PLA are, and they're clearly broader than we originally thought. And that gives us real opportunity to bring the benefit of PLA to more communities. So thank you for those. I'll just finish by saying that the recording will be available online through the Community of Practice in the next couple of days. And if Andy and Jelly are happy, I'll also make the slide deck available, if that's okay. But let me know if it's not okay, if you're because I know you're in the process of submitting and publishing a manuscript. So let me know if it's not okay to share the information. But if it is, I'll put that online as well. And if there are any questions following this that people have, then please feel free to send them and I can forward them on to Andy and Jelly, or if you have their addresses, please connect with them directly. So thanks again to everyone for your time today, and look forward to seeing you all at the next meeting. And in the meantime, stay safe and stay well. Thanks all.